Repeat the serum creatinine 12 hours after contrast studies and defer surgery if possible until the creatinine has returned to baseline. 3. Optimize hemodynamic status. Occasionally, emergency surgery is indicated in patients with marginal hemodynamics on inotrope support and an intra-aortic balloon pump, in which case one often has to accept the inevitable but frequently transient deterioration in renal function postoperatively. Correct acid-base or metabolic abnormalities associated with renal insufficiency, such as hyponatremia, hyper or hypokalemia, hypomagnesemia, hyperphosphatemia, metabolic acidosis from chronic kidney disease, or alkalosis from diuretics. Perform dialysis the day before surgery in patients on chronic dialysis. Preoperative dialysis may be of benefit to patients with moderate renal dysfunction. One study showed that this approach to patients with a preoperative creatinine more than 2.5 mg/dL significantly reduced the need for postoperative dialysis with less morbidity and significantly less mortality. In patients with preoperative congestive heart failure and hypoxemia who require urgent surgery, ultrafiltration to remove fluid frequently proves beneficial as well. H. Intraoperative measures. Intraoperative measures should be taken to try to augment renal reserve by improving renal blood flow, enhancing the glomerular filtration rate, and preventing tubular damage in patients with known renal dysfunction or risk factors for its development. First, consider performing off-pump coronary surgery in diabetic patients with pre-operative renal dysfunction. Maintain optimal hemodynamic performance before and after cardiopulmonary bypass. Use antifibrinolytic drugs to minimize the bleeding diathesis that commonly accompanies renal dysfunction, uremic platelet dysfunction. Eta-aminocaproic acid, amicar, is commonly used and is generally safe. Also, it is associated with some degree of renal tubular dysfunction without a significant change in creatinine clearance. Tranexamic acid is a good alternative. Aprocitentan came under scrutiny in 2007 because of a report that it increased the risk of renal failure as well as other adverse outcomes. However, numerous studies, including a previous analysis of the same database, have refuted this finding. In fact, it was concluded that blood transfusions were associated with adverse renal outcomes, yet aprocitentan was not an independent risk factor for acute kidney injury. One study also showed a similar risk of renal dysfunction with AEC or aprocitentan. Nonetheless, aprocitentan was withdrawn from the market in late 2007. 4. Considerations during cardiopulmonary bypass. A. Use heparin-coated circuits if available, which may be beneficial in reducing the systemic inflammatory response. B. Use a miniaturized circuit which may lower the incidence of postoperative acute kidney injury by reducing the systemic inflammatory response. Leukodeblation on pump using leukocyte-reducing filters may attenuate glomerular and tubular injury. This has been shown to lower the levels of microalbumin and retinol binding protein index to creatinine. D. Maintain a higher mean pressure, perfusion pressure on bypass around 80 mm mercury by increasing the systemic flow rate. If this doesn't raise the blood pressure to adequate levels, a vasopressor can be added, as long as an adequate systemic flow rate with satisfactory oxygen delivery is maintained, as evidenced by adequate venous oxygen saturations. A vasopressor such as phenylephrine, norepinephrine, or vasopressin can be used to increase systemic resistance. Auto-regulation of renal flow occurs down to a pressure of about 80 mm mercury, but below that, flow is pressure dependent. Nonetheless, one study did indicate that the incidence of postoperative acute kidney injury was no different with the mean pressures below 60, among 60 to 69, or more than 70 mm mercury were used during cardiopulmonary bypass. Also, urine output was less at lower pressures. Keep the pump run as shortly as possible. Generally, the longer the duration of cardiopulmonary bypass, the greater the incidence of renal failure. Avoid extreme hemodulation on cardiopulmonary bypass. Studies have suggested that there is a correlation between the lowest hematocrit on pump, usually below 21%, and the incidence of acute kidney injury, especially in obese patients. However, the hematocrit is only one factor in oxygen delivery. Since acute kidney injury is more common below a critical level for oxygen delivery, 272 milliliter minute meter square, lower hematocrits may be accessible as long as oxygen delivery is maintained above the critical level with increased pump flow rates. G. Also, moderate hypothermia may not be protective of renal function during surgery. Rewarming up to 37 Celsius degree may be harmful to the kidneys. One study showed that this produced a 40% greater chance of developing acute kidney injury than if the patient was only warmed to 34 Celsius degrees. This may occur because the kidneys may rewarm more rapidly than other organs, including the brain, resulting in hyperthermia-related exacerbation of renal injury. However, rewarming to low temperatures has its own problems, such as an increased risk of bleeding, shivering, delayed extubation, and infection. Prevent hyperglycemia during the pump run. I. Hemofiltration can be performed to remove free water and solid during and at the conclusion of bypass. This is beneficial in removing excess fluid from patients with preoperative congestive heart failure and may improve pulmonary function. By removing potassium, it mitigates the concern about using high volumes of hyperkalemic cardioplegia solutions. Hemoconcentration can optimize the hematocrit and lower the requirement for transfusions. It may improve hemodynamics, hemostasis, and pulmonary function in higher risk patients. One study suggests that the use of sodium nitroprusside during rewarming on pump improves renal function and in patients undergoing elective coronary artery bypass grafting. Also, this must not be allowed to occur at the expense of inaccessible hypotension.